time to walk through genitourinary syndrome of menopause and how this reduction in estrogen in the vagina and in the vulva may clinically present and how we treat it. I will have to apologize. I'm actually going to be going to the operating room after I give my presentation, but I will definitely follow up, Dr. Schiller, with any questions that either my amazing colleague, Dr. Chu, can't answer, if there's some directly for me. So thank you all. So moving forward, let's talk about it. I think it's something that we maybe don't talk about enough, but genitourinary syndrome of menopause affects up to 90% of postmenopausal women, and it can present in a variety of ways, from urinary urgency, frequency, sexual pain, but it also can present whenever we're younger. So even in our early 40s and up to 20% of patients who are in perimenopause. Next slide. In spite of its high prevalence, it's still underreported, underdiagnosed, and undertreated. And so we find that many women don't discuss these symptoms with their gynecologist or PCP. They may say it's a natural part of aging, and they may not know that some of those symptoms are directly from reduced estrogen in the vagina. They may also perceive that there's a lack of interest in their healthcare provider, and they don't feel like there's time to discuss it. Women also tend to self-medicate. So we use over-the-counter drugs that may be ineffective or not effective enough. There's some background noise here. Are you guys still able to hear me okay?
Yeah, we can hear you fine.
Okay, great. Next slide. So I think that apart from like clinically, and I think in order to dive in clinically on how it presents, we're gonna go through some of the clinical presentations, but I'm gonna show you what actually happens to the vaginal tissue itself, which may give us some more information. So again, genitourinary syndrome this used to be called vulvovaginal atrophy, which was a terrible name, and it made everyone feel very bad about themselves. So that name transitioned a few years ago, but it does capture that while it's this low estrogen state of the vagina, it's also low estrogen in the vulva and the urinary tract. So patients have that classic vaginal dryness. They may first notice it during intercourse. They may have vaginal burning, vulvar burning, that dryness with penetrative sex. They may find that they're not able to self-lubricate as well. And so then the result is reduced sexual function. I can't self-lubricate. I'm less aroused. I'm not orgasming because it's uncomfortable. And then it's a chronic condition. It tends to actually, even though it may present in that perimenopausal, early menopausal years, it can actually worsen as menopause goes on. And if you look at sexually active postmenopausal women, about 50% will have symptoms associated with this. So this is where a little bit of science comes in, and I'm sorry if these slides are unclear. I'm going to try to make them a little bit more clear. So on the left is going to be a normal and reproductive age vaginal epithelium. So it has, you see the two upper layers of the vaginal wall. So the top tissue is something called stratified squamous epithelium. And then there's that lamina propria, the kind of the connective tissue underneath it. And this is in patients who have normal estrogen levels. This is something that's very rich in something called glycogen, which are these big cells that have clear cytoplasm. You can see there's that blue arrow that's pointing to it. It's also non-keratinized tissue. And then you have that basement membrane or basal cell layer that kind of at the bottom. And that's where there's a different type of cell called columnar cells. What happens with atrophy is that there's thinning of that squamous epithelium up top. So you can kind of see in that middle slide, I know the colors are a little different, but if you can just look at the top layer of that squamous epithelium, it's thinner. And then in severe atrophy, it's even more thin. So that epithelium becomes really flat on the surface. So instead of like seeing like that pink, healthy vaginal tissue, it becomes less stretchy, flat, and there's an absence of what's called papillae, or just something that shows that there's absence of elasticity. When we have a reduction in those glycogen stores, we also have a reduction in something called lactobacilli, which is the healthy bacteria in the vagina. And when we have a reduction of that, we have an increase in vaginal pH. So that's why even women who are not sexually active or may not even have other symptoms, you'll have women talk about a new odor that may have presented in kind of perimenopause and menopause. And a lot of that is because of this, because the healthy bacteria, that lactobacilli, has gone down. There's an increase in unhealthy bacteria. So it's anaerobic bacteria that can grow. And then women may have, again, that odor, dryness, and symptoms associated. The other thing I mentioned earlier is, in addition to this glycogen, there's a change in that composition of the connective tissue, kind of deeper. So less collagen, not just in our face, but also in our others, both keratinized skin and then non-keratinized tissue like the vagina. And the tissue is also less strong. So this is where women, you have vaginal dryness, you participate in intercourse, you may have postmenopausal spotting just because that tissue is more thin, it's less elastic. The vagina also produces fewer secretions. And because of that less lubrication, it's more vulnerable to like those little tears that can happen that can also cause pain with intercourse. And then even taking a step back, the vagina at baseline in reproductive age women is a it's like a microcirculation environment. So there is the amount of blood flow that is present in the vagina is at baseline levels when we're not aroused or having an orgasm. The blood volume in general is really low. And so this is why even women why women will say as we age, increasing blood into this space with either masturbation or intercourse, increasing arousal can actually help with some of these as well. So it's not the primary treatment, but it can certainly help the entire like vulvovaginal picture as we move into aging. So what we see as clinicians is we're going to see some of these things visually. So we're going to see maybe some thinning of the tissue, agglutination of the labia. So the smaller lips, the labia minora might kind of stick together because there's less healthy estrogen. There can sometimes be a loss of pubic hair. And then women might have lesions just from scratching, itching that we may be able to visually see. All right. So now what treatments are available? And we move forward in this slide. One more slide. I don't know what that's an extra slide you guys get. So this is what we're doing at baseline, right? This is what women are already doing. We know that there are commercially available products. And I think just walking through first the difference between lubrication and moisturizers. So at baseline, I think women are very familiar with lubricants. They're generally added to penetrative intercourse to reduce friction and improve sexual pleasure. And this is across the entire reproductive lifespan. So younger women, those without sexual dysfunction, without vaginal dryness, may still add lubricants to enhance that sexual experience and make it more comfortable. Evidence does suggest that the use of personal lubricants is more frequently used with partnered intercourse and sexual play with a partner than solo intercourse behaviors. And a study has shown that the use of water and silicone-based lubricants may be higher, may result in higher ratings of sexual pleasure with penile and vaginal sex. So it seems to enhance the experience, but it's not necessarily the only thing that we can use for those of us who may have genitourinary syndrome of menopause. But in general, we say that's the first line of treatment, right? If you have mild symptoms, there's dryness that may initially present, but you're not having significant discomfort, you could add a personal lubricant in addition to regular sexual activity to try to manage those early symptoms. Now, when we move into talking more about lubricants versus moisturizers, this is a really important part as we incorporate this into our toolbox for managing sexual discomfort. So there's a metric that we use, is something called osmolality. And this will help as you're deciding what type of lubricant or what type of moisturizer you want to use in the vagina.
Here.
That
you underwear.
Oh, sorry. that you, hopefully this information I'll give you about the osmolality will help you select a product that's right for you. Osmolality is simply a measure of how much of one substance is dissolved into another substance. So the ocean has a very high osmolality compared to just water that you might put a small amount of salt in. So the reason it's important is because the osmolality of the products that we put inside the vagina and on the vulva can be very irritating and destructive to our bacteria that live in the vagina. So this next slide is a little busy, but I'm gonna walk you through it a little bit. But big picture is that when it's very important to know the osmolality of a lubricant or a moisturizer that we use. And so I'm going to focus on lubricants here. The WHO actually recommends that the osmolality of a personal lubricant should not exceed 380 milliliters of osmolality per kilogram. So when you have these greater osmolality lubricants, they're associated with more mucosal irritation, more tissue damage, and they can even cause some of the cells to be so irritated that they kind of slough off and die. They're cytotoxic. So high molality personal lubricants can actually kill the healthy cells in the vagina and make it more likely that that anaerobic bacteria can grow. So I think it's very important as you're selecting, and I just kind of highlighted these down here at the bottom. So I don't know if you can see those, but it's important to differentiate between those different osmolality. What you might see up here is that some of the lubricants that are most popular have actually very high osmolality. So that may be something that if you say, I use this product and it's really irritating, it could be not that you don't wouldn't benefit from a lubricant or moisturizer, it wouldn't improve your day-to-day function, but you just may not be using the right one. So moisturizers have a longer lasting effect in relieving symptoms. And that's because they are they actually bind to the epithelium and they release fluid over time. So I'll talk a little bit more about that, but let's move to the next slide here. Again, this is just talking about the pH of these lubricants. So osmolality is one thing. The pH of lubricants is also really important to consider whenever you're selecting a lubricant for vaginal or anal intercourse. So there can be an increased risk of developing, if you're using lubricants and especially oil-based lubricants over time, there's a risk of developing bacterial vaginosis or vaginal candidiasis. And that's why sometimes when women use oils, which may seem less irritating, so coconut oil, vitamin E oil, it can actually trap bacteria in the vagina and have an overgrowth of bacteria. So again, when you're selecting a lubricant, you need to think about osmolality, you need to think about the pH, and that you need different lubricants if you participate in vaginal and anal intercourse. So just remember that, because those can also be very irritating. You can't move between those two. So typically, those that tend to be the most well tolerated for women who are sensitive are going to be, I put a couple of up here, but this is slippery stuff. These are water-based lubricants that tend to be very well tolerated, low osmolality, the pH that's appropriate for the vagina. The Joe is a water-based lubricant that has silicone powder dissolved in it. And so it lasts a little bit longer than typical lubricants, but it doesn't have doesn't significantly increase that osmolality. Right. I'm going to talk more about moisturizers now. I've gone back and forth a little bit. They're both on that slide. I'm not going to show you that slide, but the moisturizers, instead of just like a short-acting adjunct to sexual or penetrative activity, these are insoluble, hydrophilic, cross-linked polymers that stick to the vagina. So they adhere to the epithelium and they retain water. And so this is nice because you can use them, we typically say every 2 to 3 days. They typically tend to be less irritating than lubricants. Again, lubricants has a pretty high osmolality, but it tends to be, but it has an appropriate pH, and it tends to be less irritating than some of the others. And I think that that shows that it's not just osmolality in general that may decide if it's helpful for you. If you read the label, it says use this every 3 days, but we use vaginal moisturizers based off of symptoms. So some patients may use it daily or every other day, and some patients may use it once or twice a week. It's not going to change the atrophy, right? It's not going to, lubricants or moisturizers are really just going to be focusing on moisture, acidity, the fluid content in the vagina, and then, and hopefully improving day-to-day function. There's also hyaluronic acid gels that women are using as moisturizers, which can also improve vaginal dryness and can actually have a similar effect to vaginal estrogen. And we're going to go into hormones here in a second. So in general, I would say if you find something that's worked for you, you find something that's tends to be well tolerated, that's great. I think you can keep using it. If you find that you're a little bit more sensitive, you might want to incorporate those other factors. I think I already gave this away, but what's the osmolality of an oil? These don't have any osmolality because there's nothing dissolved into it. So while these aren't necessarily on that osmolality scale because nothing's being dissolved into oil, they can act more like a high osmolality because they can then trap bacteria in some patients. Okay. What about hormone therapy? I mean, this is really going to be the mainstay that we use for symptomatic patients who are peri and postmenopausal and who are able to use hormone therapy. The most common and the one that has the most data is going to be vaginal estrogen, and we can move into that. Next slide. And this is one that you know is a generally incredibly safe, very well tolerated, can be used as a cream, a tablet, a ring. When you compare lubricants and most moisturizers in trials for GSM, estrogen tends to be superior. Hyaluronic acid and some emerging trials show that that may actually be similar to estrogen. But when we're using estrogen, we're actually thinking about not just the sexual discomfort, but it can improve urinary incontinence, recurrent UTIs, as well as that vaginal dryness and pain with intercourse. And so estrogen is usually considered, you know, by the time patients present to me, I'm usually going to be prescribing an estrogen therapy because they may have already tried a lot of the first line over-the-counter treatments, like lubricants and moisturizers. Next slide. So just so you have some names, the creams we use are going to be estradiol or conjugated estrogens. And depending on insurance, usually insurance covers one, but they may not cover the other. So if you do get this prescribed and it's really expensive, you can always get the other same dose, other brand, and it would typically be covered. One of the biggest complaints about creams is women will insert this at night and it doesn't fully dissolve. So they will have a discharge the next day. It can be very irritating. So some patients prefer like a tablet or a ring. If you use a tablet or a ring, you may still want to use a cream for the vulva. So I have some patients who will say, I don't want all the leakage afterward on the day after. I have to wear a pad. I thought I was done with that. We may use a tablet and then have them apply cream to the vulva at night. And so it's less of a discharge. This is the next slide. This technically is not estrogen, but it's vaginal DHEA. This is progesterone. In short-term studies, it appears to be very safe. This is more of it's an androgen. So instead of estrogen, it's more of a male type hormone. But interestingly, the endometrium is not affected. So the lining of the uterus is not affected by DHEA because the enzymes that are required to transform DHEA into estrogen, so it converts to estrogen, are absent in the endometrium. So women who have a uterus can use vaginal estrogen and can use DHEA without needing to do anything to protect the lining of the uterus. So although there's no systemic increase of estrogen and DHEA, breast cancer continues to be a contraindication for this, but we're going to talk a little bit about that in a second. And there are some, not claims, not FDA claims, but some reported anecdotal description of the fact that this may actually be effective in libido, because it may actually have an additional effect that estrogen doesn't have on the nerve endings in the vagina and the clitoris. So that's been postulated. What if I can't use estrogen? So again, DHEA may be appropriate, but it may not, because it still would be considered not recommended for women with breast cancer. Typically, that's going to be the one of the leading reasons on why we're not using or why women are not candidates for vaginal estrogen. Next slide. So a few other non-estrogen, but estrogen peripheral meds. So one of them is Osphena. This is a selective estrogen receptor modulator, and it's an oral pill that's been FDA approved for moderate to severe dyspareunia due to vaginal dryness from GSM. It has a strong effect on estrogen receptors in the vagina, but not other places. So actually less likely to affect, even though it's systemic, to affect estrogen receptors in the breast and other parts of the body. However, we still recommend not to use this in women with a known estrogen-dependent cancer or a blood clot in the past. Next slide. And then vaginal testosterone. Everyone's talking about testosterone everywhere, but you can also apply it in the vagina. There have been some small studies looking at women who have who are breast cancer survivors and who have GSM, and there does appear to be an improvement in the thickness of the vaginal epithelium and less irritation. So it is something off-label, but it is something that has been shown to be effective in breast cancer survivors. And then other options. I know we use a lot of probiotics as humans, and there are some claims by companies that, we can go to next slide, that probiotics may help vulvovaginal atrophy or GSM, but there's really minimal data. There have been some, and I'm going to reports that potentially there's a benefit in changing the balance of bacteria in the gut, but not in the vagina. And so we typically say there's very minimal evidence on the role of probiotics in treating GSM. And then next slide, we've talked about some of these moisturizers, lubricants, hyaluronic acid. Vitamin E also can be helpful in women, or has been reported in studies of women who are breast cancer survivors and GSM. However, similarly, you have to just be careful with oils. If you're having issues, you could have a new bacterial vaginosis or yeast infection. And then a very small study was done looking at fennel cream compounded for atrophy with some short-term improvement of symptoms. However, that study only looked at outcomes at 12 weeks. Next slide. Certainly, pelvic floor physical therapy can be helpful, maybe not in directly treating vulvovaginal atrophy, but it can help associated high-tone pelvic floor dysfunction, which may accompany and contribute to dyspareunia. Vaginal dilators, desensitization can help with just comfort and maybe restoring some tissue mobility. Regular sexual activity or arousal can be helpful in baseline vaginal health. We see this in both younger and older women. And then obviously anything else you want to make sure you address, like, is the patient using she has a lot of vulvar irritation, or you're experiencing vulvar irritation, but you're using a scented soap, or you're using lotion that might be drying to the vulva. I mean, all of those things you have to also be thoughtful as you are approaching women who are present with these symptoms. And the reality is most of this will probably look like several of these options, right? You're on an estrogen therapy, you use a lubricant during intercourse, you might add a moisturizer as you need to. And that's probably going to be the most complete and thorough for general vulvovaginal health. Last year, there was a big multi-society group that met. So you had all the big players who give guidance on sexual and menopausal health and illness. And they made quite a few recommendations on the screening and what the exam should look like and how we should follow up. And the hormonal and non-hormonal therapy are available, and then how to follow women up. And I think that what it really did was it just supported what we already believe is symptoms lead, right? So we see this in menopausal medicine, right? We check your labs, you're not menopausal, but you're clearly symptomatic. Same thing with this, your tissue could look healthy and normal, but you're reporting all the symptoms. It's empowering clinicians to use shared decision-making, try things, even if maybe someone doesn't fully line up with the criteria, and try to prevent it from progressing, which is something that absolutely can progress. Next slide. A big win with the FDA last year was that that black box warning was removed from vaginal estrogen. We've been saying that forever, like, thank goodness, take that off. It was dated back to 2003 and extrapolated from systemic therapy from the Women's Health Initiative. And we all know how harmful the interpretation of that has been for women. And so the great news is that that label's removed for low-dose vaginal products. And there's a lot of studies now looking at how to use, thoughtfully use estrogen in women who historically we've said it's not appropriate, especially our patients with breast cancer. So I'm hopeful that we'll have more data as we move forward. So bottom line, low-dose vaginal estrogen is first-line prescription treatment. Very, very, very little systemic absorption, no increased risk, at least in our review of the well-done clinical trials of endometrial or breast cancer, though I think the recurrence risk is what people are more concerned about, and that data is not as clear, but still likely low risk. The cardiovascular risk of using low-dose estrogen therapy, no increased risk of stroke, even women who have cardiovascular disease, which is huge. And like I said, we are increasingly using this for quality of life for women who are significantly symptomatic. And so we just want to partner with their medicine team and their oncology team to make decisions that are best for them. You may have read about fractional lasers and CO2 and the YAG, and all this is a hormone-free treatment option. And there have been some very well done sham-controlled RCTs that just show no consistent benefit. And so while I think this was initially like the white horse that was going to come in for women who couldn't safely use more hormonally derived therapies, it doesn't seem to be the case. So it's not approved for GSM, not endorsed by the Menopause Society, which I think is the best place to get most up-to-date information. So I would just make that decision in step with your clinician. So finally, genitourinary syndrome of menopause is super common. There's a lot of options that are available, and what might work for you may not work for someone else. And I think just keep being open-minded about that you may need different types of therapies at different times, but it is a lifelong treatment, especially if we're using estrogen. So it's something we want to start early and maintain because GSM is progressive. So I think once we find something that works and you tolerate, we'll want you to continue to use that forever. And I think that the biggest win of last year was just the low-dose estrogen no longer carries that black box warning. Regarding resources, you can certainly get a lot of your resources online on the Menopause Society. There are some apps that can be available for menopausal support. And I don't have any ties to any of these. You can flip to the next slide. But and you may have communities or resources or groups that you follow. I think that just always double check where you get your information from, even now is more important than ever. Another author you might want to look at is Jennifer Gunter. She's an OBGYN who has wrote extensively on menopausal disease and health and wellness, and really is very evidence-based with her recommendations. So that's all I have for my part of the presentation. I know that we're going to do the questions later, and so I can follow up if there's anything that I'm giving it over to Dr. Chu. So if there's anything that, which I know you can answer probably all of these better than me, but I am excited for everyone to use all of these in a capacity that makes sense for you.
Yes. So we got a question in the chat. Can we share that last slide again with the resources? And yes, we can do that. And we're happy to send that information out via email to all the attendees today as well. Thank you so much, Dr. Carey, for being here. Do you need to run right now, or do you want to take a couple questions? Totally fine. I know you have to run.
Sorry.
No, you're good. You're good. No, we'll manage the questions later. No worries.
Yeah,
no, thank you so much for being here. Totally appreciate it. Thank you. Fantastic presentations, just packed with great information. So
thank you guys for doing this.
You.
I think it's so important, and I love what you guys are doing. So please keep up the work in educating and getting the messages out. So thank you all.
Bye. Thank you.
Bye-bye.
All right. So now we will move on to the second portion of our presentation with Dr. Chu. So and Cecilia, it looks like we're sharing the slides again. So if you want to pull those up, that would be helpful.
Yeah, thank you for having me. And thanks, Cecilia, for pulling up those slides. All right. Well, I mean, that's a really hard act to follow. Dr. Carey is amazing. And so my presentation is going to be on some things that can be impacted in menopause, which would be pelvic floor disorders. So we're going to go through a couple common conditions, and then I'll take any questions and maybe try to answer some that might have come up from Dr. Carey's presentation as well. Okay. And just to clarify, I'm a urogynecologist. So we specialize in diseases affecting the bladder, the vagina, and the bowels. We're going to focus a little bit on the bladder today, the vagina, as far as pelvic organ prolapse, and then we're going to talk about the pelvic floor as well. And I see there's a couple PTs on today, so we have some experts here as well on the pelvic floor. So I'm excited to kind of go through all of this. All right. So first, we're just going to briefly go through some anatomy and just kind of go through what the pelvis looks like on the inside. So when I say pelvic floor, there's a lot of things we think about. What I'm specifically referring to is going to be this group of muscles and connective tissue that form the bottom or the floor of the pelvis, right? So a lot of times we describe this almost like a hammock. So it is this hammock of muscles that is attached on both sides by your hip bones on both sides, as well as your pubic bone in the front and your sacral bones in the back. And it holds up everything inside the pelvis. Here you can see that in the front, so towards the abdomen, towards the pubic bone, we have the bladder, and then the urethra that we pee through. Behind that, we have the vagina. So they're really close to each other, the bladder and the vagina, very closely related. At the top of the vagina is usually the uterus, unless there's been a hysterectomy where the uterus has been removed. And then behind that is the rectum. So a lot of organs in this very important space. Next slide, please. And I would say this hammock has two major jobs, and they're two very different jobs. So the first is about support. So it has to hold everything up against gravity all day long. The second thing, it would be control. So it has to squeeze to hold urine and stool, and then it has to relax in order to help you empty, to have a bowel movement, to urinate. The pelvic floor often also relaxes for intercourse to make that more comfortable. Most of the problems we'll talk about today is probably coming from one of these two jobs not working the way they should. Okay, next slide, please. Okay. So what changes after menopause? So Dr. Carey did an excellent presentation about this. And the first thing, that she mentioned is estrogen, right? She mentioned this already, but briefly, the tissue of the vagina, the urethra, and the bladder, so not just the vagina, but the bladder and even the tube you pee through, the urethra alone, they're all estrogen sensitive. So when estrogen decreases or declines after menopause, all of that tissue in the bladder and the vagina and the tube you pee through, the urethra, it all gets thinner and drier and less elastic. And so everything kind of starts to loosen, it tends to thin out. And so menopause can put more strain on the pelvic organs, as well as putting more strain on the pelvic floor muscles, which we'll see in the next slide. So the pelvic floor can start to become dysfunctional after menopause, just as we get older, we lose muscle mass all over. And especially after menopause, that can accelerate. This can happen in the pelvic floor as well, so it's no exception. We can see decreased muscle mass. Also, we tend to overuse those muscles over time as well. And with aging and with menopause, then it's harder for those muscles to recover. And so when there's injuries, big injuries, small injuries, it's going to be harder for the muscle to repair itself as well. So all of that increases the risk of these pelvic floor disorders that we're going to talk about. So even in patients, oh, sorry, even with patients without pregnancies, without prior deliveries, never had pelvic surgery, menopause can still itself be that factor that suddenly causes issues and where you start to have symptoms. Okay, next slide, please. The third thing we think about with menopause is chronic inflammation. So, estrogen is really good to help calm down that inflammation in our pelvic tissues and our pelvic muscles. And when estrogen levels drop, that brake comes off, and then you tend to get more general inflammation in the body in general and also in the pelvis. So, this can cause tissue changes and weakness over time. And so, between that thinning muscle, weakening muscles, and then this inflammation in the area, menopause can really impact the pelvic floor from different directions. Okay, next slide, please. So, I want to put some numbers to this because this can kind of change the way we think about these issues. These issues are common, but we don't talk about them a lot. So, 1 in 2 women over 50 has a pelvic floor disorder. About 80% of women after menopause have those genitourinary syndromes of menopause symptoms, those vaginal and urinary changes from estrogen loss. 1 in 3 women will leak at some point in time in their life. And this one also is really important that less than 1 in 4 women with these symptoms will ever discuss them with a doctor. So a lot of people are just quietly suffering under the assumption that this is what aging looks like. And it's not, because there are things that we can do to treat or improve these symptoms. Next slide, please. So for the rest of the talk, we're going to focus on 4 conditions. Of course, there's many other pelvic floor conditions, but these are probably some of the most common. The first, we're going to talk about overactive bladder, which is what we call that sudden, hard to postpone need to go. There's also stress incontinence, which can also cause urine leakage, but it's a different kind. So it's usually leaking with coughing, sneezing, movement, exercise, anything that puts pressure on the bladder. It's usually smaller amounts of urine that leak compared to overactive bladder, but not always the case. There's also pelvic organ prolapse. So that is when the vagina kind of bulges down at the vaginal opening and you feel pressure or bulging there as the support tissue of the vagina loosens and weakens. And then one that, can contribute to all of these, and one that I want to particularly pay attention to, is pelvic floor dysfunction. So the pelvic floor muscle dysfunction in particular. So that's when muscles are tight and or weak, which can cause a whole number of symptoms: urinary, bowel, pelvic pain, pain with intercourse. And I think this is often under-recognized when we're facing these other issues as well. So these 4 have different reasons that they happen and different treatments, but a lot of women have all of these at the same time. Next slide, please. So the first one, overactive bladder. I gotta go, right? I need to go right now. So what happens is that the bladder muscle, for some reason, has become, or the bladder nerves have become a little more sensitive. So even when the bladder isn't full, it's giving a signal to the brain that you've got to go and that you're full and you need to go right away. In addition to that, the bladder isn't listening to the brain anymore. So the bladder squeezes when it shouldn't, before you get to the bathroom. So you can start to feel like you got to rush to make it to the bathroom. You might leak before you make it to the toilet. You may also feel like you got to go more frequently than you used to, and you might be waking up at night more than you used to. So that would be overactive bladder. Next slide, please. So this is a little more of like a clinical slide, but I think everyone can learn from this. So the formal definition of overactive bladder is the feeling of urgency, that rush to go that's not normal, with leakage that's associated with that urgency, and can be with daytime frequent urination and nighttime frequent urination as well. About 16% of women to 20% of women in the US experience this. It's more common as we get older, in patients with higher BMI and with patients who've had pregnancies and deliveries. Usually you don't need a lot of workup for overactive bladder. So a history, a focused exam, sometimes a urine analysis, especially if we're concerned about true UTI symptoms. Things that may be helpful and may not be completely needed include, potentially urine culture if we're concerned about UTI. Checking people, checking their emptying, which we call post-void residual, or even a bladder diary to note how often we're urinating, how often we're getting up at night to go, how much we're drinking, and how much we're urinating and leaking at the same time might be helpful. Things like bladder testing, or what we call urodynamics, looking inside the bladder with a cystoscope, and imaging are not usually needed for uncomplicated overactive bladder. All right, next slide, please. Okay, so what makes overactive bladder worse? Now, this can also be things that we act on, and so this is really great to go through. We think of a lot of things that we eat and drink as potential bladder irritants. So the big players are going to be caffeine, alcohol, anything with carbonation, and artificial sweeteners. So all of these can cause, one, they can be diuretics, so cause you to make more urine. And two, they can make the bladder squeeze more and make you feel more that urgency and frequency and gotta go symptoms. So we recommend that trying to cut these out as much as possible. Lower estrogen levels, as we discussed, vaginal estrogen can help to treat that as well. So that is always something that can be helpful in addition to some of the other things we talk about when it comes to overactive bladder. Aging, unfortunately, we can't do much about that, but there are ways that we can try to age more healthfully. Smoking can definitely worsen overactive bladder, as can constipation. So stool being right next to the bladder can irritate the bladder as well and cause urinary symptoms to be worse. The other thing is too much or too little fluid can be bad. So that saying of 8 glasses of water a day is not necessarily true if you have overactive bladder. And if you have too little water, that can make the urine really concentrated and irritate the bladder as well. So being moderate with water, and we usually say like 40 to 60 ounces of water, and spreading that out throughout the day can be really helpful to not make overactive bladder worse. Okay, next slide, please. Okay, so treatment for overactive bladder is kind of like a stepwise ladder. We step up if we need to, but we often can use things from each of these steps to help treat it. So first line is behavioral. So we talked about cutting down or cutting out those bladder irritants, drinking enough but not too much water. There's also bladder training. So kind of trying to reconnect that brain to the bladder and trying to decrease some of that urgency and lengthen the amount of time between when we have that signal to go and when we actually go to the bathroom. Pelvic floor exercises or pelvic floor physical therapy in particular can be very helpful for this. Has been shown in like 60 to 80% of patients to really improve overactive bladder symptoms. And of course, treating reversible causes, such as UTI or other conditions that may make overactive bladder worse. Second line is medications. So there are 2 main medications that we choose from. This is going a little into the weeds, but it's anticholinergic or beta-3 agonists. We'll talk about that next because there's actually a really important distinction between those medications. And about 60% of patients that take medications improve if they're able to take them and if they're able to be consistent with it. And then we have third line, and these are third line mainly because they're a little more procedural or surgical. The first would be what we call neuromodulation, or trying to change the nerve signaling of the bladder. So that can include posterior tibial nerve stimulation, PTNS, or sacral nerve stimulation. So either stimulating the nerves of your ankle that connect to your bladder, or stimulating the nerves of the bladder themselves, or Botox into the bladder muscle itself. Next slide, please. Okay. So this slide is more for our clinicians, and it's about how we choose medications, but I think this is important for everyone to know. So traditionally, we have used anticholinergic medications. They're an older medication that's been around for a very long time. There is now increasing concern that anticholinergic medications, even the ones that are used for overactive bladder, are associated with increased risk of cognitive impairment and dementia over time. So in general, we do want to avoid them in older adults, but also even in younger adults, especially with a medication like this, which is a lifetime medication, that we really want to try not to use them if possible. If I can't do an anticholinergic, beta-3 agonist, which we'll talk about because of cost or insurance reasons, usually I would recommend picking one with lower blood-brain barrier penetration, so the medications that are less likely to get into the brain and affect the brain. So that includes, usually my pick would be trospium. It's really a large molecule, so less likely to get into the brain. Darafenacin is more specific to the receptors on the bladder, so also a good choice. And there's been some studies saying that tolterodine is less likely to get into the brain as well. Otherwise, like my preference is for the beta-3 agonist. So this is mirabegron or vibegron. Mirabegron, in some studies, have bumped up blood pressure a few points, maybe anywhere from 1 to 5 points. In patients with uncontrolled blood pressure, we can't use that medication, but it does avoid those cognitive side effects. And a newer one called vibegron, which came on the market in around 2020, this has no effect on blood pressure. So this could be good for patients who do have uncontrolled blood pressures. For most women, if there's not a cost or insurance issue, a beta-3 agonist is the way to go. All right, next slide, please. All right, so the next thing we're going to talk about is stress incontinence. So that's going to be leaking with coughing, sneezing, exercise. So stress in this case, it's not like mental stress. It means physical stress or anything that puts pressure on your bladder. So I like to picture this as the urethra, the tube we pee through, kind of sitting on this supportive shelf. If that shelf weakens, then anything when you push down on it, like with a cough, sneeze, jump, laugh, it's going to push urine out of the bladder through the urethra. And usually it's small amounts, it can't be large. Usually it's not associated with that urgency. That would be more that overactive bladder. And that's how you tell those two apart. Okay, next slide, please. So the main thing we think is what we think that lack of support is going to be called urethral hypermobility, or sometimes the urethra itself just kind of widens and opens up, and we call that intrinsic sphincter deficiency. Both of those things can cause this kind of leakage. We don't typically do bladder testing for this. Oftentimes, we can have patients cough or push in the office, and we see urine come out, and that's one test for stress incontinence. We may want to check to see if patients can empty well in the office, and checking a urine analysis, making sure that there's not an infection, can be helpful in certain times. That bladder testing and that urodynamics testing, that more invasive testing that we do as urogynecologists is not necessary for all patients with stress incontinence. But if patients have a lot of overactive bladder, if the symptoms don't match findings, if they have failed prior treatment or they've had prior surgery, then that would be a sign to send them to us for testing. One thing to note is a lot of patients have both stress incontinence and overactive bladder and have that mixed picture. We call that mixed incontinence. And one thing to kind of remember is that things that help with stress incontinence, like pessarine surgery, are not going to help with overactive bladder, and vice versa. So medications for overactive bladder are not going to help with stress incontinence. So knowing that ahead of time is going to be really helpful. All right, next slide, please. So you can see that the things that make stress incontinence worse overlap a lot with the overactive bladder lists. So things that injure the pelvic floor, pregnancies, deliveries, lower estrogen levels, higher BMI, smoking, coughing, and chronic heavy lifting. And constipation, straining can also put a lot of strain on the tissues of the pelvis and can make stress incontinence worse. All right, next Next slide. Okay. So treatment for stress incontinence. Again, this is kind of like there's conservative and more surgical treatments. So some of the things we often start with are, lifestyle changes. So weight loss can certainly help decrease stress incontinence by 50% in patients who have had weight gain or are overweight. Fluid management, same thing, avoiding those bladder irritants, watching how much or how little you're drinking, and bladder training. The next thing is pelvic floor physical therapy, which is also great for overactive bladder. And patients who undergo pelvic floor physical therapy, especially with someone who is able to make sure that you're doing the right exercises, they're 8 times more likely to report a cure versus those who don't undergo treatment with physical therapy. We also can fit you with this silicone device, which we call an incontinence pessary. It usually looks like a ring with a little knob at the top, almost like a little diamond ring. It can be used just with activity, or some people use it all the time, and that can help support the urethra as well and is non-surgical. Next slide, please. But if conservative options aren't enough, then there are other options as well. So we have something called urethral bulking. Traditionally, it was done in the office. More often or not, now it's done in the operating room under some light anesthesia, IV anesthesia. It's a 5 to 10-minute procedure where this water-based gel gets injected around the urethra. The one with the best evidence right now is what we call Bulkamid, which has up to 7-year data showing that the majority of patients feel improved even at 6 to 7 years after this injection. This is also repeatable. But overall, probably less success than the sling that we'll talk about next. But it's a very short procedure with less risk and very little downtime. Our gold standard is still going to be our mid-urethral mesh sling. This is a same-day procedure. It takes about 30, 40 minutes. At 10, 12 years, about 85% of people feel like it's still improving their urinary symptoms. Because it is mesh, though, and it's a foreign body, there are some risks, but the risks are pretty low. So the things we talk about with mesh is like it being exposed in the vagina. That risk is less than 4% with this kind of procedure. So this is a very good option for a lot of women. All right, next slide, please. The next thing we're going to talk about is prolapse. When vaginal support weakens, the vaginal walls start to drop towards the opening. And this is what we talk about when we're talking about pelvic organ prolapse. So sometimes I actually describe it as vaginal wall prolapse specifically, because it's not your bladder causing it. It's not your uterus causing it. It's not your bowels causing it. It's actually because the vagina has lost its support that this is happening. And what would it feel like? So it's usually a bulging that you're feeling at the opening of the vagina that you can either see or feel. Some people will have some pressure or inability to urinate with this, but the main symptom of this is going to be that feeling of tissue coming out of the opening of the vagina. This affects 1 in 4 women, and it can be very manageable. Next slide, please. So there are a lot of misconceptions about prolapse. So, it is really common. So about 1 in 2 women will have some amount of prolapse on exam, but the number of patients who actually have symptoms from it is a lot lower. So anywhere from 3 to 15%. And you don't have to live with this. This is another thing to understand, that this can be treated. Prolapse doesn't usually cause pain. It usually doesn't cause urinary or bowel leakage. So we want to make sure that we understand that if we have pain or urinary or bowel leakage, we want to investigate that, because that could be caused by something else. The other thing to know is prolapse is not dangerous. So a lot of women come because they're scared that their organs are going to come out of their body and fall onto the floor. That is not the case. And also, it is not cancer. So the bulging from the vagina is not cancer. So it's good to be reassured that this is not a dangerous condition. The other thing is, this doesn't automatically mean you need surgery or a hysterectomy to remove your uterus. So, those are things that we can address when you come see us. Next slide, please. Okay. Again, we have all kinds of levels of treatment for prolapse. For some patients where you're not really bothered, but it's just you wanted to find out what this was, we can provide reassurance and education. You don't necessarily need any treatment for it if you're not bothered by it, because it's not dangerous. Other things include pelvic floor physical therapy. So learning to support the vagina properly can help with the symptoms of bulging. And about 10% of patients can even see some improvement in some of their bulging symptoms to a certain extent. in early stage prolapse. The pessary, so that little silicone device we talked about for stress incontinence, we can also use that to support the vagina so the walls don't come down. It's fittable in clinic. We can remove and replace it. It can be used for long term or for temporarily, depending on what you desire. And then lastly, we do have surgery. There are different types of surgery. It really depends on the prolapse you have. Usually it involves lifting the walls of the vagina, either with stitches or with mesh. It may or may not require hysterectomy. In patients who aren't pursuing intercourse anymore, we actually can shorten the vagina. That's called colpocliasis, which is one of our most helpful surgeries, or our most successful surgeries that we have. Next slide, please. This is a slide for our clinicians, some things not to miss. Some things are that prolapse can actually hide stress incontinence by kind of bending or kinking the urethra. So repairing prolapse isn't going to fix stress incontinence and might actually make stress incontinence worse. Fixing prolapse also is probably not going to treat overactive bladder. Those things are probably conditions that we're going to have to treat separately from prolapse alone. And we always check to see if there's leakage of urine by pushing up the prolapse before checking for leakage. The other thing is hysterectomy alone is not going to work in most cases for prolapse. So if the top or the other walls of the vagina are coming down, removing the uterus is not going to re-support those walls. So you may want to add a support procedure or pair with a urogynecologist for a combined repair. And then, treating the vaginal thinning can be really helpful to provide comfort, whether or not we're going to do a pessary or surgery for prolapse. Next slide, please. Okay. And then the last thing I want to address is pelvic floor dysfunction, because a lot of patients with all the other the problems that we talked about today will also have pelvic floor dysfunction. And that's when those pelvic floor muscles are either too weak or too tight or both. So if it's too weak, you can't hold or close the urethra properly, and that's linked to leaking, linked to worsening bulging from the vagina. The If muscles are too tight, then they're clenched and can't fully relax. That can cause pain with intercourse, incomplete difficulty with emptying the bladder and bowels, and urgency. It can also lead to leakage sometimes as well, which is a little confusing. If muscles are too weak, we can work on strengthening and coordination. If muscles are too tight, doing Kegels, like strengthening initially, may not be the right thing. It could actually make it worse. So the initial work usually is focused on relaxing, and it should include internal work. When muscles are weak, doing Kegels alone at home or working on muscle strengthening could be appropriate, although most people still would benefit from guidance with a pelvic floor physical therapist. When muscles are too tight, I would not probably recommend trying to do home exercises and really seeking out a pelvic floor physical therapist. And unfortunately, muscles can be weak and tight at the same time. So that's where a pelvic floor physical therapist would be very helpful and an individualized plan. Next slide, please. Okay, so this is kind of a review of everything we happened, just an overview of the 4 disorders. Overactive bladder, again, the bladder squeezing when it shouldn't, you're rushing to the bathroom, medications, behavioral management, and physical therapy, as well as nerve stimulation, Botox are our main treatments. For stress incontinence, loss of support of the urethra, so you leak with coughing and pressure on the bladder. Watching fluids, physical therapy, weight loss, pessary, and surgeries are options. For prolapse, that's a loss of support of the vagina and you feel vaginal bulging. And for that, physical therapy, pessary, and surgery are available. And for pelvic floor dysfunction, muscles too weak, too tight, or both can cause all of these symptoms. And our first treatment is pelvic floor PT. But there are some other things like vaginal muscle relaxants or injections that can be done to help as well. Next slide. When to seek help, honestly, if the symptoms bother you, tell your doctor about it. You don't need the medical words for it, and you can just tell your doctor the symptom that bothers you the most, and keep track of how often they're happening, when they're happening, and what makes it better or worse, so that we can have a better idea of what might be helpful for you, and ask for a referral to us, to a urogynecologist, and we are happy to help. And next slide. For clinicians, when to refer to us, overactive bladder, I think that is very manageable up through medication, and we prefer beta-3 agonists. But for things like nerve stimulation or Botox, we're happy to talk to patients about those options. For prolapse, if patients are symptomatic, we're happy to see them. If patients have any difficulty emptying their bladder, let us know, because that may need to be treated more urgently. And if you patients have prolapse and need a hysterectomy, we're happy to combine with you for combined repairs. For stress incontinence, if someone is considering a procedure or surgery, that's a great time for a referral to us. And bladder testing is not necessarily required to start the initial care. And then pelvic floor dysfunctions. Most patients have dysfunctional pelvic floors that are tight and weak. Kegels may not be right, and most are unable to do them on their own. So, a good pelvic floor physical therapist is really important. And I know we have a lot of them on this call, actually. And then you might consider this diagnosis if patients have symptoms that aren't responding to, your typical management. Patients have recurrent UTIs, but it's kind of a atypical picture, or patients with pelvic pain symptoms probably have some amount of pelvic floor dysfunction, even if there are other things going on too. So referral to us or a PT or even Dr. Carey can be really important. All right, I think that is my last slide. Oh, wait, just general things. So symptoms are common, not just aging. All these things can change after menopause. It's not dangerous, but you don't have to live with the bother. Pelvic floor PT. I love them. And then start the conversation with your doctor. All right. Happy to take any questions. I'll try to answer some questions for Dr. Carey as well, but otherwise I'm happy to refer it to her as well. Thank you.